Zoom for this first episode of Season 2 of CNS INSPIRE series that will feature stalwarts who have done commendable work in the field of health and development. Our guest for today has more than 35 years of experience in public health and has held senior positions in the Ministry of Health and Family Welfare, Government of India. Starting as a medical officer in 1988 at the Directorate of Health Services, Government of Delhi, he rose to become the Deputy Director General of National AIDS Control Program and then Deputy Director General, Central TB Division in 2018. He led one of the biggest national health programs in India, the National TB Elimination Program, or NTEP, which was formerly called RNTCP. The largest national TB prevalence survey of India was also conducted in 2019 during his tenure. The National Strategic Plan 2017-2025 was also shaped under his leadership. He has also served as a nodal officer at the Global Fund for TB, HIV, and Malaria and has held the position of Regional Director, Southeast Asia Office of International Union Against Tuberculosis and Lung Health. Currently, he is President, CMO of Molbio Diagnostics. And despite wearing so many crowns and despite his numerous achievements, I have yet to come across such a modest, soft-spoken, and down-to-earth public expert. I am honored to welcome none other than Dr. Kuldeep Singh Sachdeva as the first speaker to inaugurate Session 2 of CNS INSPIRE series. Welcome, sir. We are very grateful to you for finding time for us today.
Thanks, Shobha, and thanks for that generous introduction. Yeah.
No, that is very little of what actually I should have said, sir. Sir, CNS has had the privilege of following your stunning journey and speaking with you several times in the past. In 2016, when you were leading India's National AIDS Control Program, we had interviewed you during Season 1 of CNS INSPIRE series. Since then, a lot of water has flown over and below our heads. We would like to rather take you back to the moment when you took charge as Deputy Director General TB in 2018. And one thing we will like to know more about is that brilliant national strategic plan that was shaped under your leadership at NTEP. Please share your reflections on implementing NSP and taking India towards TB elimination targets. Over to you, sir.
Thank you, Shobha. So, NSP, we were not doing for the first time in 2018. We had done that one earlier. Only thing is that the ambition changed thereon. And what we realized that if you have to eliminate TB, you have to have some instruments to do that. And we recognize that NSP can be one instrument to advocate and get a buy-in from political leaders and also from bureaucracy to see what we want to do. I mean, if you put something on paper and articulate it well, you get more eyeballs and more people to listen to you. And that articulation, it was overtly ambitious. We must admit that, and it was very intentional to make it overtly ambitious so that at least we are able to show the pathway of TB elimination to them, and also sort of say that this is what we need. And generally, as you know, when you ask for something, you don't get whatever you ask for. So the idea was that we get not incremental but substantial hike in support, both human resource as well as financial, and which is very evident in the with the fact that the budget almost tripled in next 5 years. Even though we actually asked for 6 7 times more what we were getting, but we could actually take it to 300% more level. Yeah. I can't hear you, Shobha.
Sorry, I muted myself.
Yeah.
But it was a very forward-looking plan from what we have seen, and taking India towards TB elimination through detect, treat, prevent, build. And even at that time, it was talking of finding all people with TB, detecting TB, using the best of tests and gradual removal of microscopy. There were, I think, and it was a costed plan. At least for 3 years, it was a costed plan, I think, and
We
projections for,
costed that till
yes, for 3 years, I think.
2025.
Yes, yes, and
Yeah,
so yes,
no, with the revision, we costed it till 2025.
yes,
So costed it for actually 7 years at that point of time, so that
yes.
we sync with the 2025 goal. Yeah.
Okay, we would really want to hear some life-changing milestones you achieved during that. Of course, NSP, I think, was one milestone. Another was the National TB Prevalence Survey. But any other milestones and achievements you would like to share with us
I think the
during your
most
journey?
significant milestone in TB has been engagement of private sector. So, and we started that very early on. We realized that we were at one point of time stuck at a maximum TB case notification of 14 to 16 lakh cases for almost 3 4 years. So, with our best of efforts, we were not able to increase it, and it was a common knowledge even then that almost 70 80% of the patients approach private sector first, and then we started actually opening up program to private sector, being more friendly to them, giving them all the parks, take money, had an intermediary, and I think the most significant is that private sector notification from just about under 2 to 3,000 is currently about 8 lakhs now every year under the program. So almost one third, every third patient now comes from private sector. So two by the government program, one by the private sector program. So that's been the most significant achievement, and what we say estimate the number of cases every year and what we are able to reach out and put on treatment. There is still a gap, but that gap has been reduced substantially. So now we almost reach 95, more than 90% of the patients that we estimate are available in the country. That's the most
Okay.
significant achievement. There have been numerous achievements. I think the most significant is you are able to reach everybody, and your all efforts then start picking up from there. Yeah.
Yes, but we would like you to share a few more. I know there have been very many maybe significant
Yeah, so
achievements. Yeah.
the private sector is one.
Mhm.
The other is introduction of replacement of smear microscopy with molecular diagnostics. So as a policy, we had it about 6 7 years ago. In practice, we also know that there is always a policy and practice gap, and the policy is again an enabling provision to get more resources, ask for more resources. So initially, we had just about I think dozen of molecular testing equipment. Initially, Gene Expert at that point of time. Today in country, you have almost 8,000 test molecular testing equipment. Most of it is now Indian made rather than the foreign made. So almost the balance is also skewed more in front of favor of Indian made molecular testing equipment, which is about 7,000, and the other one, the foreign made, is about 1,000. And with this, at that point of time, we estimated we were doing about a crore of presumptive TB examination every year, and we estimated that these machines will be able to take care of all replacement of all smear microscopy. So the challenge currently has been on the funding side of this, but in principle, the replacement has been accepted. We are doing almost a crore to almost about a crore of tests with molecular diagnostics. But now the presumptive examination has gone up from 1 crore to 2 crores. So that way, we are almost 50% of people are getting tested with the newer diagnostic methods very quickly, very early. So that's another significant rollout of newer drugs. I mean, we, with the advent of which is bedaquiline, predominant now, delaminates, all newer drugs. The best part is now that the treatment duration has been cut from about 2.5 years to almost 6 months to 1 year for drug-resistant TB. The outcomes have improved from almost about 30% to nearly 75% today. So earlier we were losing almost 70 out of 100. We now are able to treat and cure almost 75 to 80 out of 100. So that's the most significant patient friendly introduction of newer drugs. And few other newer initiatives have been engaging community at scale. So community engagement has actually now gone on scale. So each district, each state has so-called TB volunteers or TB mitras, and they are helping program to reach out to the community. So that's another. And we also rolled out what is called as crowdfunding for patients with TB Mukt Bharat Abhiyan. And this is one of its kind in the world. So we are actually ordinary people in the country are helping their fellow patients and fellow citizens to uh, sort of help negotiate the journey of cure to TB and supporting them with nutrition, livelihood, whatever they can in whatever small way, say 1,000 rupees or 2,000 rupees a year for family. So almost 10 to 15 lakh, which is say 2,000 rupees a year. That's also one of the most significant achievements under the TB program.
Okay. I would like to mention one more achievement. You are talking of cost and so much of money coming in. You had shared with us that in the year 2000, you had helped in developing essential drug list and essential list of surgical consumables for Delhi government. And through a little simplification of the process of procurement of drugs and surgical consumables, you were able to save more than 40%, result in more than
Yeah,
40% of savings.
savings
So,
to, yeah.
yes. So that I think was a big achievement. And then there was no shortage of drugs at that time because of that. I think you saved around 200 crores Indian
Yeah, so
rupees.
that was at even in TB program when bedaquiline was first introduced.
Hmm.
First patient course was for $17,000.
Okay.
Now it is $200.
Yes, yes.
See
So,
the difference.
yes, right, right, right.
Yeah.
You have talked about the indigenous molecular test. I will be coming to that later also. Any bitter memories about? Would you like to share any bitter memories or any uh, thing which
So
you
bitter,
thought could?
bitter,
Yeah.
you should not call it bitter because that's
Hmm.
a challenge of
Yes,
program managers. If
yes,
there are
yes.
no problems, then we are not needed. So that's what I tell all my colleagues and juniors also, that we are there. I'm a program manager because something is not going well.
Yes.
If everything goes well, then you are not needed.
Hmm.
So the challenge is sometimes to convert your aspirations into a policy and implementation takes time. So we have seen challenge initially in introduction of molecular diagnostics. I mean, they were introduced somewhere in 2012, but by the time we could actually take them to some scale, it was 2014 and 15. So those are the initial challenges. We also wanted to shift from an alternate day therapy in TB earlier to a daily therapy. That took quite some time.
Yeah.
It was hard convincing the policymakers because costs of drugs were increasing. But private sector was not getting roped in because of the intermittent therapy. So we realized early on that if we don't change our regimen, we will not be able to get private sector. So that convincing took some time, generation of evidence, etc. Took some time. It took about 2 to 3 years to make that change because the cost of drug increased about 1.8 times at that point of time. But you see dividends in the form of that. Now we have been able to detect 50 to 60% more patients than we were detecting then.
Yes.
So if we were able to reach 15 lakh patients now, we are able to reach about 25 lakh patients every year now. So the results are there to see now. I mean, which sometimes policymakers and bureaucrats are not able to see what we are trying to do. They look at core economics, but the economics is patient welfare and TB elimination future costs. But those results are very well there to now see. So similarly, first time we tried to introduce bedaquiline, uh, the challenge was not more on the policy side. The challenge was more on the implementation side. Many practitioners were very reluctant to put patients on a new drug, fearing side effects, outcomes. It took us almost 3 years engaging with them, state by state, district by district, with physicians to make them confident to put patients on new drugs. So, but these are the challenges. I mean, you may call them whatever bitter experiences, frustrating experiences, but I think this is what all managers have to negotiate.
Yeah, rightly so. And I remember when when bedaquiline was introduced, I remember when I was also hounding you with questions that why is not everybody getting bedaquiline? And in your very simple, suave manner, you were really addressing all of them. I remember all of those.
Mm.
And when we had met, I had met you first, I think about 15 years ago, and then the alarm on drug-resistant TB had gone out already. And
Yeah.
you were one of those who was tasked to scale up India's capacity of managing drug-resistant TB. And as you have said right now about microscopy, and also at that time there were very few bios safety level
Well,
3
yeah,
labs.
yeah, yeah.
Yeah, and where drug testing for drug-resistant TB could be done. Uh, and even that was very time consuming. And today, as you have mentioned, we have innovative new technologies for diagnosing TB. And now, not just every city, I think the new molecular test you were talking of, what that is TrueNat, which has
Yeah,
been built in India,
yeah.
uh, it is it is even at the block level. Many blocks, I think, have got it in India, not
So
just
almost
cities.
all blocks have TrueNAT or a
Yes,
molecular diagnostic.
yes.
In some cases, more than one in a block, because now you have close to 8,000 TrueNAT, around 1,000 plus gene experts. So
Mm.
if you have 6,500 blocks, you have almost 1.5 times of that capacity available for molecular diagnostics. So you have, on an average, you have 1.5 per block.
Okay. Mhm.
Some may have more, some may have
Yes.
less. So
Mhm.
that may be there. But on an average, you have now sufficient capacity for testing everybody with the molecular diagnostics.
Yes. So I would just like to mention here for the those who are uninitiated in our audience that our indigenously made TrueNat test is the only WHO recommended point of care, decentralized, laboratory independent, and battery operated molecular test globally. Please
Yeah.
correct me if I'm wrong, sir.
No,
That
that's
is
right.
one. Yes.
That's right. The beauty is
Yeah.
that you can actually carry it in a
Yes.
briefcase.
Yes.
Do it anywhere. So I mean, we recently met someone from a UN agency, and we took that to his room and showed him that it's possible. So
Right.
now, that's what they are doing in active case finding, home to home search. Now you can carry your machines along with you or on a mobile. So truly closer to home,
Oh,
not in the bedrooms now, but
no, but
almost close to your
Yes,
doorsteps.
yes, yes.
Yeah,
Almost at the doorstep.
yeah,
Yes.
yeah.
And
Almost.
I recently read a Stop TB partnership social media post where it shared that TrueNat molecular test is making a major impact in 9 countries as part of their innovative new technologies project. And I think it's being used in around 70 countries or so.
Almost, I think 80 countries
Okay, okay.
use this platform. Yeah.
Yes. But sir, microscopy is still being used to test for TB, and we are still missing TB cases. So how can we find all TB and replace microscopy 100%? Is it uh, as soon as possible? Is it that difficult, or what are
So
your thoughts?
again, the question was economics versus the patient benefit. Even at that point, introducing, I said molecular diagnostic initially took some
Mm,
time. You see, microscopy costs 50 rupees.
mm,
This will cost you at least 500 to 600 rupees. But the benefit is that you are detecting them much earlier,
Yes, yes, yes.
2 months earlier. And again, we are seeing some of those benefits being translated now. I'm talking of 2012, 2013 when we were trying to introduce. As I told you, the fixed dose combination or daily therapy, when we introduce, we see additional 10 to 12 lakh patients every year. Similarly, with the introduction of molecular diagnostics, you now see a decline in incidence, which is much more than what we had historically had. So we historically had about just about 1% decline in incidence. Now we are close to reaching 5% in some areas. On an average, it is between 3 to 5%. So decline in incidence is almost now 3 to 4 times what it used to be in those years, and that is where now, because of these molecular diagnostics, newer drugs, private sector engagement, we can think of elimination now. At least it is in the dream. We never dreamt it in
Yes,
2015.
yes, right.
The world did not dream of TB elimination prior to
Mm,
2015.
mm, mm.
The
Yes.
dream only came when there were enabling provisions.
Right.
There is a molecular diagnostic, there is a private sector engagement model, and there are now treatment options which make you can have 100% cure. So imagine a disease which is 20,000 years old.
Right.
What changed 10 years ago that now you're talking of elimination?
Mm.
The only
So,
change which happened 10 years ago or 12 years ago is that now you can diagnose TB in an hour
yeah.
and be 100% sure it is TB. You can treat TB almost close to 90 to 100% cure, and you can reach almost 90-95% of the patients. So the three path breaking things have made you dream now, and the fourth, which is being added now, is X-rays, portable or ultra portable X-rays, which again you can carry with you and do X-ray anywhere. It's at the doorstep, inside patient's house, inside their drawing rooms. You now can click X-ray pictures. So this is the fourth major change, which will accelerate the dream of TB elimination. So ultra portable X-rays, and with that, we are also coming up with the algorithm or paradigm called population level screening. So screen the entire population with X-rays. Those who are X-ray show some sort of X-ray shadow, subject them to TrueNAT or a molecular diagnostics. Those who are positive, treat them 100 with 100% cure, and that is where we aim that we'll be able to accelerate TB decline in TB incidence very fast and achieve our goal of sustainable development goals very quickly. I'm not giving a time frame to it, but I think we can do that very quickly.
Thank you, sir. Sir, I would like you to share also the importance of X-rays and why verbal screening is not enough. I think your prevalence survey also showed that there were many asymptomatic TB patients. So that idea of verbal screening does not work always. Can you
So
please?
so verbal screening, you will only get those who are have a very high index of
Yes,
suspicion. So
yes, yes.
by the time you
Mm,
ti- begin to manifest some symptoms or illness,
mm,
you are too advanced.
yes.
So they say almost 60% of the patients never complained of any symptom. They will complain of some symptoms 6 months down the line, 8 months down the line, 3 months down the line, but then the disease will be in an advanced stage, and they would have transmitted this disease to
Yes.
their family members,
Yes.
their friends, their co-workers. But if you do an X-ray, screen them in an X-ray, you detect them when they are not transmitting the disease. It is in very early stages. And that is what is now going to make the most impact on decline in incidence. So I see a question there. There is no
Yes.
radiation risk from ultra portable X-rays. It's almost you get less than 1% of the dose
Yes.
which you get on conventional X-rays. So if you do, of course, 100, 150 X-rays on the same individual, the risk will match.
Yeah.
So, but you are not going to do that. You are
Mm,
just going to click one picture.
mm,
So it's near zero risk with the ultra portable X-rays, and this is what is now going to be a game changer
yeah.
in the TB field, and this is what is now going to see you on take you to an accelerated decline in incidence. I give a time frame, don't give a time frame, but
No.
maybe within next 5, 10 years, you can actually see India becoming the disease becoming not being a public health problem at all. You will not totally eliminate it, but it will be the incidence will be so low that like in most developed
Mm.
countries.
Okay. That is good hope. And yes, we are really hoping for that if things go the way they are going. Yes. Uh, Also, how do we ensure, yes, that the drugs are there and success rate has increased, but still we are, as somebody had said, that as of now, one in five of drug susceptible TB patients and one in two of drug resistant TB patients are getting cured in India. Is that true, or please correct me if I'm wrong?
So
Uh,
there are various ways to look at statistics. Okay,
okay, yes.
so you say if you have 100 patients in the community
Mm,
and you reach out to 80%,
mm.
and you cure 80% of them, you are actually curing only
Yeah,
60% of
yeah. Mm,
estimated in the community.
right,
But
right.
practically, now we are able to reach 90% of the
Mm,
patients and cure 90%. So
mm,
we are very close to actually curing 75, 80% of the people in the community. The more you intensify your effort, the more the implementation improves, we'll be very close to actually curing almost 90% of the patients in the community. So that's one. Drug-resistant TB, I already alluded to earlier that now we are able to cure almost 75% of those detected.
mm.
Again, how do you
Yeah.
look at
Yes,
statistics? So
yes, yes.
I have 100 MDR TB patients. I detect 75% of them, cure 75% of them. So actually, what I'm doing is I'm curing about somewhere around 60% of the total cases being available. So the key lies in reaching out to all the patients, detecting them very early. So that is where I said ultra portable X-rays,
Yes,
your molecular diagnostics will help you to close this gap.
right.
And if you are able to reach 80%, 90%, then that's good for public health programming. We'll be able to see a rapid decline in incidence.
Yeah. And it will also prevent transmission, as you
It,
said, because
yeah,
the later you diagnose TB, the more that infection has spread in
yeah,
the
more it
community.
is transmissible. Yeah,
Yes, yes. So it's in the interest of everyone, even those who do not have TB. It's in our interest also that the transmission is cut off and we prevent the transmission, I
yeah.
think.
So that's why we say if I have hypertension, it's my problem. If I have TB, it is your
Yes,
problem.
yes. Right, right.
Or any other infectious disease
Yeah,
for that matter. If
yes,
I have
yes, yes.
COVID, it is your problem.
Mm.
If I have diabetes, that is not your
Not my
problem. It is
problem.
my
Mm,
problem.
mm. Right, right. So you had once said that we should develop models of care, rightly so, which are community oriented and public health oriented. What, according to you, is the complete casket of TB care? Is it just diagnosing and treating, or does it go beyond that?
So now with again newer technologies being available, we are now revising the cascade of TB care. So initially the cascade of TB care used to start the moment the patient feels some symptom of disease,
Mm,
which according to prevalence survey, out of 100, only 40% will give you some symptom. So if you start your cascade with 40 people, and then your earlier question is very right. By the time you finish your cascade, treat 90% of those 40
mm,
people, diagnose them early, you are only treating 35 out of 100.
yes.
But now, if you start your cascade by population level screening, by X rays, portable or ultra portable, whatever you
Mm,
call them,
yes.
then you will be able to catch almost 90, treat 90 of them. So, which is you will be able to reach 80 out of 100. So, see, from 35, you immediately jump to 80.
Right.
And do it over a period of 2, 3, 4, 5 years, and you will see a rapid decline in incidence. I anticipate you will see almost 60 to 70% decline in incidence. It will not remain a public health problem by then if you are able to do that for next 5 years. So what is crucial is that you screen with X-rays everyone, and the bonus or the sort of the what you get in addition is that you
Vision.
also are able to get other diseases if they have any other thing on the.
Yes.
So you are trying to offer a holistic care there. And
Yeah,
then,
but then, sir, I just want to ask a question here
yeah.
because I have been following you for quite a long time. And
Mhm.
sir, what about the role of AI? I mean, because we are just trying that out in places where we don't have these portable X-rays or ultra portable X-rays, because we are just foraying into that arena of like cuff for TB. Because in some of our inaccessible areas where we can't have these portable X-rays or ultra portable X-rays or till they come. So we want to know what is the role of AI going to be? Like we are employing cuff for TB.
So AI is not cough for TB. AI is improving your diagnostic capacity through a machine learning. It
Yes, sir.
can be with an X-ray, it can be with a cough sound, or it can be with any other thing. So cough for TB is being investigated by many people. Currently, it has not reached that stage where we can say that we can use it with certainty to find out people who are presumptive TB. So there are still a lot of false positive, false negative. Those issues are there. Having said that, people are refining these algorithms very quickly and
Okay.
taking it further. So what you need to do, what people are doing with cough for TB is that they are trying to refine their algorithm with those who test positive and did the cough for TB actually throw them up as positive presumptive TB. If you try to define algorithms with an X-ray and a cough for TB and see that how much overlap you can get, you will get better results. So people are not trying various algorithms, but I expect that within again 6 to 12 months you will have some solution on cough for TB, which is as good as an X-ray. But still, at this point of time, a solution comparable to an ultra portable X-ray is not there with cough for TB with AI. But we are expecting that with so many uh, scientists working on this, we will have a solution soon. Currently, it's showing somewhere about sensitivity of between 60 to 70%. We still want to improve on this sensitivity. But having said that, something is better than nothing. If you
Yes,
don't
sir.
have an ultra portable, you can do, but with a clear frame of mind that you are like still likely to mess with this technology.
So because we want to use this in our active case finding, because where we won't have portable X-rays or ultra portable X-rays available. So
That's
at
what
least
I'm
we'll
trying
have one
to.
more tool.
Yeah, that's what I'm trying to tell you. If you screen people for X-ray, it's very sensitive.
Yes.
So all those who are presumptive TB will get captured. You will get additional cases who may not be presumptive TB. They may have other diseases. So whatever you detect as suspicious or presumptive with X-ray, you will find TB only among them.
Yeah, right, sir.
Those who are tested negative with X-ray, you are unlikely to find TB among them. Of course, there'll be some cases, but with cough for TB, currently that is not there. If cough for TB tells you that somebody does not have TB, you may still have a group of people who will have TB from that group which has been excluded. So this is the algorithm which is being currently refined. So do what you can also generate your own evidence at some point of time and feed into the national evidence. But that's what you should do. But yes, it's good that you are trying to close the gap between. It's anyway, it will be better than verbal screening and other things. You can also combine it with verbal screening if you're looking at a very cost efficient tool. But bear in mind, it has still not reached that level of sensitivity and specificity that you can use it with certainty.
Right, sir. Thank you,
And
sir.
and thank you to the STO of Kashmir for asking that question. And actually, it has helped all of us in clearing the doubts. Thank you very much, ma'am. Uh,
Welcome.
yeah. So, sir, having spent decades in India in helping shape India's TB and HIV responses, what was it like taking charge as Regional Director, Southeast Asia Office of International Union Against Tuberculosis and Lung Disease? Moving from a national role to a regional role, which covered Southeast Asia.
No, it's always, I mean, when you have an idea and you also can actually replicate your success in some areas into
Yes,
other parts of the globe, and it's all ultimately TB is transmissible because people move.
yes. Okay, that's a good one.
If people don't move, then you can confine to your own geography.
Yeah,
And
yeah,
these
yeah.
days, people movement has become
Right,
much
right.
more frequent
Mhm,
than it used to be earlier.
mhm.
What you saw with COVID. So, what they were trying to stop your movement at that point of time.
Yes, 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 yes.
You can do it for a limited period of time, but
Mhm,
you can't do it for a chronic disease like TB. Though
mhm.
we debated at that point of time, could we have done this for TB at some point of time, stop people's movement and so that it gets
No,
confined to one area? But then these are not practical
right. No.
solutions. So bearing in mind that these are not practical solution, people keep moving, so TB will keep getting transmitted.
Mhm, mhm,
Except the very developed countries which don't issue a visa.
mhm, mhm, mhm.
If you have any
Right.
sign or any X-ray shadow and you even test positive on a latent TB, they s- subject to a battery of tests. So they are trying to see that you don't import TB into their country. Some countries are doing that, but that's an extreme step because they don't want to import TB into their country. More or less, you will not be able to stop people movement. So
Yes.
we have to have a global solution.
Mm,
Some solutions are very good in India. If you look at the community engagement, private sector engagement, and the engagement of crowdfunding and the for-profit sector in TB, these are success stories in TB.
right.
Look at
So,
Southeast Asia. India has been able to saturate almost 50% of the expected people who should be put on preventive TB treatment. No other country in the within the region Southeast Asia has reached even 25% of that expect. So we are way ahead in that. So similarly, the introduction of newer drugs was much better in other parts of the globe.
mm,
People implemented the introduction of bedaquiline, delaminate, protamine much earlier than we had been able to do that. So there are lessons and cross lessons to be learned from all
mm,
sides. So it's a good journey to get that global view and
mhm,
see how where we can find the best fit for your interventions. The interventions on ultra portable X-rays and population level screening are also coming from the other. These learnings are also coming from other parts of the globe.
mm,
So and they are very practical, down to earth learnings which are implementable. The issue is with resources, but you can also modify your implementation as per your local context. So things are working in a better way in many states in that context. So it's a cross pollination of ideas, cross fertilization of interventions, which helps here.
and now from the regional level, you have moved on to the global level, sir, transitioning from building rock solid diagnostic capabilities in India to getting a chance to influence diagnostic capabilities worldwide as President CMO at Molbio, which is manufacturing TrueNat, because now you are in a position to influence other countries as well. So, would you like to say something about that?
No, no, I mean, we now I firmly believe that total replacement of microscopy with molecular tests, TrueNat or any other molecular tests, population level screening, screening with ultra portable or portable X-rays is going to be one core key intervention which will take you towards TB elimination. And this will happen very quickly if you are able to do that and sort of seed this idea in the entire globe. So while some countries are doing that, not everybody is able to screen with ultra portable X-rays, screen with the molecular diagnostics. So there are you'll see many countries which are where we were about 10 to 15 years earlier. They are still there. So we should be able to, in the interest of the patients and the population at large, we should be able to sort of steer them or guide them to take a pathway which will sort of take them closer towards meeting sustainable development goals and reduce future costs. as I alluded, the economics you see after 10, 15 years. We see the economics of doubling our cost on fixed dose regimens now. We see the economics of introduction of bedaquiline 10 years from when we introduce now. So we'll see the economics of investment in ultra portable X-rays, replacement of sphere microscopy very quickly in next 5 to 10 years.
Yes, and I think they have done
Yeah,
modeling and studies about $1 spent on TB. How much is the return you get? So that
yeah,
it makes a lot of economic sense also. You
yeah.
get a lot more return than what you're spending.
Yeah,
But
so
as you, yes.
models and models, you are still actually not very convinced about those models. But
Mm.
now you see what you modeled 10 to 15 years ago, their results are
So that's,
in
yes,
front of your eyes. So you
yes,
can as well trust your future models that
yes.
they will also pay off in a similar manner.
Yes. So you have summed up so many things, sir, but once again, looking forward, what needs to happen and happen differently so that we achieve that goal of eliminating TB as soon as we can?
So one enabling provision which we need is a vaccine.
Yes. Okay.
And I'm 100% sure you will see a globally approved vaccine in next 2 to 3 years. So they are all in phase three clinical trials,
Mm.
and you should get a vaccine very quickly. And that'll be final push in that armamentarium towards TB elimination. So you will have completed done the entire spectrum on the science side of it. So once you have all spectrum on the science side of it, then
Yes.
there is a spectrum on the management or implementation side of it,
Mhm.
which the program managers then need to show to the world that yes, they can do it and they'll make it happen.
Okay. Your advice and message for those working in public health and anything else you would like to share, which I might have missed out.
No, I say if you can dream big, you actually can
Yes.
make it happen. So I've seen, I mean, in my own journey, I've seen whatever you set out and decide to do, you're able to do it. Your time
Okay.
frame may vary.
Mm.
Somebody may be able to do it, convert something into a policy in 1 year. Somebody may do it in 2 years. But if you are persistent, you will achieve it. And that's what I've seen, that if you keep sticking to your conviction, you are able to make it happen. And so dream and keep sticking to your conviction. You will be able to achieve your targets.
Okay. Uh, there is a question for you, I think, in the chat box. What is your message for transitioning from decades of clinical work to decades of public health administration? Any reflections or message on that?
No, both sides are equally satisfying. It's not that one is better than the other. It's only as you go through your life journey, things keep changing. But in public health, your one policy intervention with one stroke can benefit millions and lakhs and crores of people. In clinical, you are more personalized care, so you see the immediate reward in forms of gratification, etc. In public health, gratification comes much later. So that's why I'm saying what we did 10 years ago, we see that gratification now.
Mhm.
But in clinical work, you see the gratification immediately from patient, from relatives, etc. But both sides are equally rewarding, equally challenging. I like the medical science per se. You touch human lives and you make
Yes.
a difference.
Okay. So I think we are really very grateful to you. And we were talking to Dr. Kuldeep Singh Sachdeva, who needs no introduction, and whatever I said about him is just a drop in the ocean of what he really is. So thank you for being with us today, and thanks to the audience for listening to the golden pearl words of Dr. Sachdeva. Thank you very